So this is the second webinar that we organized in the framework of healthy sailing. Today's topic is the norovirus outbreaks on cruise ships, risk factors, and assessment of control measures effectiveness. So my presentation has two parts. The first part is an introduction and general information about gastroenteritis, acute gastroenteritis, and norovirus outbreaks in general. And the second part, I'm going to report the results of a systematic literature review we conducted in the framework of Work Package 3 and in the framework of the foundation report. We will start with some basic information because we have also partners that with different backgrounds. So I will say for public health, for people that are participating with public health background, very well-known information, but because the audience varies, I will give an overview at the beginning about acute gastroenteritis. It can be caused by viruses, bacteria, protozoa, a release of toxins from bacteria or fungi that have grown in foodstuff, or by chemical contamination of food or water. For cruise ships specifically, the most common agent are viruses and are acute gastroenteritis and specifically caused by norovirus. There are differences between virus infection and bacterial infection in regards to the onset of symptoms, the incubation period. For viral infection, this is sudden and ranges between 24 to 48 hours. For bacterial infection, is usually longer. Vomiting is usually present in virus infection, but in bacterial infection may be present, and we have other differences for symptoms. For other symptoms like diarrhea, for viral infection often present, usually very watery. For bacterial infection, almost always present, and maybe bloody depending on the pathogens. For viral infection, this is usually mild. Bacterial infection can be more serious. The duration of symptoms for viral infection is usually 1 to 2 days, and often for bacterial infection, often 5 to 10 days. The cruise ships have the reputation that they are the most, that they are hotspots, let's say, if we can say this for norovirus, but this is not true if we compare the frequency in other settings, land-based settings, and here we can see the frequency that the most frequently outbreaks are reported in hospitals and in long-term care facilities for elderly people, and less often at the schools and nursery, and less often, of course, in cruise ships. But in cruise ships, the outbreaks receive media attention. That's why we have more published reports, and they are more often in the news, the outbreaks in cruise ships, comparing to other facilities. Here we have some characteristics that facilitate norovirus transmission, and these can explain why it is very difficult to prevent and control, even if hygiene measures are applied very strictly. So low infectious dose in any infection can be caused even with 18 virus particles and up to 1,000. The norovirus particles are present at the stools of people in high numbers, in very high numbers. And if you can compare this with a low infective dose, you can understand how easily it can be spread if people do not wash their hands, or if a surface is contaminated and is not cleaned and disinfected properly. The virus can be detected up to 8 weeks after symptom onset to people that have been infected, with a median of 4 weeks, and even longer in people that are immunocompromised. And there is a genetic diversity. We have over 30 genotypes. The immunity is long-lasting. In most of the studies, the immunity can last less than 6 months. And immunity also for one strain does not necessarily mean that the person is protected by other strains. So if it will be infected with other strain, it will not. It is possible to be infected by another strain, even if recently has been infected from another strain. And different genotypes can infect humans over their lifetime. Norovirus is resistant to common disinfectants. Guidelines say that we want 1,000 ppm concentration of chlorine solutions to disinfect, and with a contact time from 5 to 10 minutes. So you can understand how resistant it is to disinfectants. Norovirus is also can be spread by vomiting and can be particularly effective route of norovirus spread. And we have multiple modes of transmission. It can be spread through the fecal-oral route, vomit-oral route, foodborne, waterborne, environmental, and direct person-to-person spread. Here we can see results of a study that analyzed data from about 3,000 norovirus outbreaks. And of course, we can see that the most frequent mode of transmission is person-to-person, and the most frequent facility are healthcare facilities. And the strain and the genotype that is more frequently found is the one that you can see with green color is GII.4. The secondary attack rate in a study that was conducted in household outbreaks showed that the secondary attack rate was significantly higher among those living in a household with 2 or more primary cases and at least 1 primary case with diarrhea. In this study, they analyzed different factors, risk factors, and this was the most, the factor that was more significantly associated with higher secondary attack rates. Now, about the infection control measures, the outbreak identification is very important, early outbreak identification. And these are some standards that they are used for land-based premises. Of course, when we define this, we have thresholds to define a possible start of the outbreak. This enables initiation of enhanced norovirus infection control measures. Guidelines say that if we have 2 or more associated patients with gastroenteritis onset within 24 to 48 hours of each other, then we can have an indication in premises like hospitals that we are going to have an outbreak. And if it is not possible to have laboratory diagnosis, then we have other criteria that we can use to differentiate actually norovirus outbreaks for other bacterial outbreaks. If we, from the mean duration of illness, from the percentage of vomiting among the cases and the incubation period. In the definition that we use in Europe, and it is included in the European Manual for Hygiene Standards and Communicable Disease Surveillance on Passenger Ships, the definition is for acute gastroenteritis is acute diarrhea, 3 or more episodes of loose stools in a 24-hour period, or what is above normal for the individual. So if an individual does not have at all, does not have normal diarrhea and it has 1 episode, then it is considered above the normal for one person. And another part of the definition, or if we have vomiting and at least one of the following symptoms, vomiting plus one or more episodes of loose stools in a 24-hour period, or vomiting and abdominal cramps, or vomiting or headache, or vomiting and muscle pain, or vomiting and fever. This is the definition, and of course it is common with CDC, Vessel Sanitation Program, so that cruise lines can use the same definition and cannot change the definition when they are sailing in different regions. Now, what is the definition of an outbreak? Our outbreak is an increase in the number of cases of gastroenteritis above the number normally occurring in that ship over a defined period of time and itinerary. For reporting purposes, there are thresholds. Of course, all cases of gastroenteritis must be reported through the Maritime Declaration of Health, but additional reports are needed when we have 2% of cases among passengers or among crew. And the second report when this has reached the 3% among passengers or among crew. So we need to remember now that we have a definition about outbreak, that it is increased number of cases more than what we normally expect. And the second threshold that is used for reporting purposes, and this is the 2% and 3%. And this should not be confused. We should not say that we have an outbreak when we have reached the 2%. The outbreak starts long before, probably. Here at the university, we analyzed data from a cruise line, historical data, and here we calculated the probability of having an outbreak depending on the number of GI cases reported in every 1,000 passengers, the first 2 days of the cruise and the first 3 days of the cruise. And you can see that, for example, if the first 2 days of the cruise we have 4 number of GI cases every 1,000 passengers, we have a probability of an outbreak of 11%. If we have the first 3 days of the cruise, 3 cases per 1,000 passengers, then we have about 15% probability of an outbreak. Other examples of thresholds that are used by the industry or in other regions, by other programs: 6 gastrointestinal cases within 6 hours, 1% of guests on ships with less than 1,000 passengers, 0.5% of guests on ships with more than 1,000 passengers, a cluster of gastroenteritis cases in one area of the ship, or 0.45% daily attack rate is indicative of a pending outbreak. These are various thresholds that are used. Now about hygiene, of course, hand washing is important for 20 minutes before and after contact with infected persons. And of course, for cruise ships, we have other guidelines that were presented in the previous webinar: wearing of appropriate personal protective equipment when there is a risk for infection, and for when we're performing a cleaning, disinfection, or we're going to be in contact with possibly contaminated areas. We said about the cleaning and disinfection, the level is 1,000 ppm with a contact time of 5 to 10 minutes. And for hard surfaces, non-porous surfaces, but we have other surfaces that we cannot disinfect with chlorine solutions, and we need to use other methods, physical methods with steam, or with other chemicals that have been proved to be effective in eliminating norovirus from surfaces. Isolation is a very important measure, of course, in cruise ships. For passengers, isolation must take place for 24 hours after the end of the last symptom for a period of 24 hours. But for food handlers and other staff, like in the medical facilities or other staff that is coming into contact, that is in more direct contact with the patients, then again the isolation time is 48 hours. Now the second part of this webinar concerns the results of a literature review and meta-analysis on preventing and controlling norovirus outbreaks on cruise ships. This is the title, and also says that calling for behavioral change strategies of travelers. We have drafted the paper. We have prepared a manuscript reporting these results. It has been submitted to your surveillance. It has been reviewed, and now we are waiting for the results. So what I'm going now to present is has not been yet under peer. We have not incorporated peer review results. This is the list of authors. This work had started. This work had started before the start of Healthy Sailing project, but it was completed and with additional data collection by performing again the research strategy and data collection and extraction, and the analysis also was repeated within the framework of Healthy Sailing project. The study purpose was to assess prevention and control measures implemented during the outbreaks on cruise ships, to identify risk factors contributing to outbreaks, and to identify modes of transmission by systematically reviewing published outbreak reports. And a meta-analysis also was conducted to estimate attack rates of norovirus outbreaks and identify risk factors. The PRISMA guidelines were applied. We searched PubMed and Scopus databases, and also we asked from the US Vessel Sanitation Program reports, outbreak reports that were not available online. And also the reference lists from relevant articles were searched. The search, here you can see the search terms that they were used in the search strategy. The inclusion and exclusion criteria. The inclusion criteria were laboratory confirmed norovirus outbreaks on cruise ships, attack rates among passengers and crew members, written in English language and published between 1980 and March 2020. The eligibility criteria regarding the inclusion timeframe were defined to include the period prior to COVID pandemic, and the literature review that is currently taking place in the framework again of the Work Package 3 has covered the period after the pandemic, and is going to report the results after the pandemic. Articles reporting outbreaks due to norovirus or cargo ships or sailing boats or not meeting any of the inclusion criteria were excluded. Outbreaks were considered those that occurred during a cruise in which the cumulative number of cases was greater than what would normally be expected. The threshold for reporting an outbreak was an attack rate of 2% or more for either passengers or crew. And norovirus outbreaks were considered those where fecal samples from at least 2 infected individuals tested positive for norovirus using RT-PCR or other methods that is specified in the methods section of the paper. Data extraction was conducted using a pre-designed data extraction form. Data extraction was completed independently by 2 reviewers. The mode of outbreak transmission and the risk factors were determined after considering results of the analytical epidemiological study conducted as part of the outbreak investigation in the original papers. Factors were considered as significantly associated with becoming ill if a p-value was calculated as less than 0.05 in multivariable analysis. And the epidemic curve and other risk factors identified in the primary studies were considered to determine if an outbreak spread was through person-to-person transmission. So we said, as I mentioned before, PubMed and Scopus. We collected 181 papers. Then finally, we included 13 papers that met the eligibility criteria, 13 papers, and also we analyzed data from 5 investigation reports provided by CDC. So we had a total 18 documents that were analyzed, and we did the data extraction, and I'm going to report now the results. All studies investigated cruise ship outbreaks with laboratory confirmation of norovirus and the distribution of questionnaires to passengers and crew members. In 11 studies, the authors investigated risk factors by conducting either a case control study or a cohort study. One study included both types of study design. One case control study only investigated specific food items, and behavioral risk factors among travelers were investigated in 3 of the 13 published studies. Data extracted from 18 studies, as we said before, concerned 26 cruise ships and a total of 45 outbreaks. Data on attack rates were available for only 26 cruise ships and 43 outbreaks. 10 articles included a risk factor analysis. In regards to the cruise itineraries, the majority of them sailed in the Americas. In Europe, 13%. In China, 4.5%. In the Pacific Ocean, 11.4%. For one ship, there were no available data about the itinerary. The most popular destinations were the Caribbean and Alaska. And of course, now we're speaking about the outbreaks that we analyzed in this paper. In all cruise ships, 26 norovirus was isolated from fecal samples. In more than half of the outbreaks studied, the norovirus was identified via RT-PCR. Besides fecal samples, rectal swabs were taken in one cruise ship. Serological tests were taken in 2 cruise ships in Hawaii, and environmental samples were taken on 4 cruise ships. The positive environmental samples were found in only one ship. These samples originated from a toilet, the handle of a disinfection container, and a restaurant. In this table, we can see the attack rates of each norovirus strain. The maximum attack rate for the total ship population, as well as for the passengers, occurred in outbreak caused by the GII.4, followed by norovirus serotype UK2. The most commonly occurring strain was NOR-GII.4, Farmington Hill strain, with 11 outbreaks and an attack rate of 6.65%. Now, in regards about the cruise voyage length, the higher attack rate was in cruises that lasted 11 or more days. About the mode of transmission, here you can see that most of the outbreaks caused by person-to-person transmission. We had multiple modes that also included person-to-person transmission, 5. Foodborne outbreaks, 2, only 2. Person-to-person and environmental, 5. Waterborne, 2. 2 outbreaks. And of course, the higher attack rate was reported in a waterborne outbreak, 31.71%, and followed by foodborne transmission. We had a total attack rate of about 20%. About the risk factors that were reported in these outbreak reports and published reports that we studied, in 8 outbreaks, the risk factor that was reported was having an ill cabin mate. Poor hygiene in 6 outbreaks, common exposure at the ship place, 5 outbreaks, ill traveler prior to embarkation, 4 outbreaks, consumption of food, 3 outbreaks, consumption of food and common exposure at the ship place, 2 outbreaks, consumption of water, 2 outbreaks, and traveling with a group before embarkation, 1 outbreak. Here we summarize the control measures that when introduced, the authors reported discontinuation of the outbreak. So these are the set of measures that were reported by the authors. And here we can see that in 4 outbreaks, when the ship removed from service for 1 week, cleaning and disinfection and ship inspection, after implementing these 4 measures, in addition, of course, to the routine measures that are implemented, then the outbreak stopped. Other measures were delaying embarkation in the subsequent cruise in order to implement measures, cleaning and disinfection, informative messages to passengers and crew members about hygiene, ship inspection. This was implemented in 2 outbreaks, and indeed the outbreak stopped. Ship inspection out of service for cleaning and disinfection, but here they do not define for how long in 2 outbreaks. So we can see what the authors report as the most effective control measures in stopping the infection chain. Now, about the modes of transmission, the majority of outbreaks in cruise ships were spread from person to person, highlighting in particular that cruises lasting more than 7 days provided greater opportunities for person-to-person transmission. And as we said, as we have seen in the previous slides, as the number of the length of cruise increases, also the attack rate also increases. Waterborne or foodborne outbreaks, as a result of poor hygiene practices on board, have not been published over the past 20 years. So this proves that the health and hygiene protocols currently, the last years are implemented by cruise lines, have prevented effectively waterborne and foodborne outbreaks. In recent years, the only published report of a foodborne outbreak is coming from already infected material, raw food that has been used on board. And this will be reported actually in the second literature review that we're going to publish. Norovirus outbreaks can occur on cruise ships that maintain excellent hygiene standards, including rigorous implementation of prevention and control measures. Of course, this is also highlighted by studies that they have associated scores from inspection of cruise ships, and they have associated this with cruise ships that have reported outbreaks and there is no association. So this is possibly due to the fact that cruise ship scores cannot reflect the performance of passenger measures for prevention of person-to-person norovirus outbreaks. So the factors that contribute to person-to-person transmission cannot be checked through routine inspections or is not currently captured in the inspection programs. Behavioral issues were examined in only 3 of the 13 publications. Behavioral risk factors during outbreaks that were reported include that ill passengers tend to underestimate or ignore gastrointestinal symptoms. Ill passengers do not limit their activities, which may lead to further virus spread. Ill passengers were less likely to believe that isolation and/or hand washing is effective to prevent disease spread, less likely to wash their hands after restroom use, and less likely to believe that hand sanitizer was available for public use. And this all, of course, compared to healthy passengers. And this demonstrates that behavioral risk factors play an important role in the development of an outbreak. So the currently applied measures need to be reconsidered, considering also that recent outbreak reports published on the website of US CDC Special Sanitation Program. If you check now the online published outbreaks, these are for 2023, 13 outbreaks, including 10 norovirus and 3 of unknown causative agents. But of course, this may have changed because this I checked some time ago. Maybe now all are reported as norovirus. Prevention and control of person-to-person transmission relies heavily on individual behaviors, performance of personal hygiene, compliance with isolation measures, and self-reporting of symptoms. So new behavioral change prevention strategies must be introduced, applying principles from behavioral and social sciences. WHO also highlights this about the prevention of infectious disease in general, and says that behavioral and social sciences evidence can contribute to and complement other public health efforts that focus on the non-medical factors that influence health outcomes. So we suggest that innovative approaches are needed to develop strategies underpinned by behavioral theory to help understand determinants of the traveling public's behavior, including cruise ship passengers, and design appropriate interventions. Now, in 8 norovirus outbreaks, the most common risk factor was having an ill cabin mate. And this is another very important thing that we need to reconsider. Isolation measures require separation of ill people from those who are well. This is by definition how we must perform isolation. We need to separate ill persons from healthy persons. But this is not possible in fully booked cruises. We do not have empty cabins where persons that have symptoms of gastroenteritis can be isolated. So the practice that currently is implemented is the isolation of sick passengers from one family or one group of people that are staying in the same cabin. If someone has the gastroenteritis, cannot be removed from this cabin. So 2, 3, or 4, or even more people may stay in the same cabin and share the same toilet. So possibly, this is one factor, that there is no space for proper isolation individually in a separate place. This is the first factor. And the second is the possible passenger and especially families may not be willing to isolate in separate cabins. So even if we tell them to separate and we say that the mother and one of the children maybe should go to another cabin, or only one family member should move to another cabin, then this is very difficult for families to accept. And they prefer to be all together in the same cabin, but they do not isolate all the persons. The persons that have not symptoms, they are going out of the cabin, and then we may have spread. But we understand that from this practice of isolation, we may double or even double the cases, or we may even make 3 cases or more by isolating one person in the same, by isolating persons that have symptoms in the same cabin with healthy persons. And of course, this may lead to continuation of person-to-person transmission. So our recommendation is, even if we do not have space to isolate many persons, the first cases at least must be isolated individually, at least. Passengers not reporting symptoms, passengers may not be willing to report in order to avoid isolation measures that would hamper their vacation. And isolation practices and enforcement policies need to be reconsidered, incorporating application of behavioral science theories and practices, of course, to change this behavior. Also, cruise lines offer free cruises if someone has diarrhea and will be isolated and will not enjoy the cruise. So some cruise lines, they offer that people can stay in the next cruise, or they offer other tickets for another cruise. Early detection of cases, of course, as we understand, is very important. Our review found that in 4 outbreaks, ill passenger prior to embarkation was a common risk factor. So screening also when embarking is an effective measure, but again, we rely on how honest the passenger will be to report symptoms at the embarkation. But ill passenger prior to embarkation is a common risk factor, and if we have a way to early detect such cases, probably we will prevent large outbreaks. And of course, this we can see in relation to the study that I presented in the results that I presented in the previous table, where we can see that the higher the number in the first the first days of the cruise, the higher then the probability of having an outbreak. Cruising the Pacific Ocean, and specifically in destination in China, was associated with a higher proportion of cases among passengers. This could possibly be explained through exposure of travelers to local community outbreaks and endemic disease during excursions ashore, or consuming products purchased from local markets without previous assessment of vendors' food safety standards. And this highlights not only the necessity of purchasing food from approved and previously assessed food suppliers, but the ability for food traceability to quickly recall foodstuff not suitable for human consumption. So in the European manual, it is a requirement, of course, by the European legislation that all foodstuff on board must be traceable. Attack rates among passengers and crew. The average attack rate of passengers was much higher compared to the weighted average attack rate of 4 crew members. And this can be explained by the limited or lack of direct contact with the passengers, between crew and passengers, and of course, several other factors influencing the immunity and resistance to norovirus. Of course, they have most of the cruises, the mean age is lower in crew members than in passengers. Our study has several limitations. The meta-analysis was based only on published articles. The estimator of the total effect size might be biased in favor of positive results, and indeed, our study, there was evidence of publication bias. While in many studies, the information about the attack rate was determined by a formal reporting of all cases, and in other studies, the attack rate was estimated by distributing a specific questionnaire. So it is expected, of course, if we distribute a specific questionnaire, we expect to have more cases, to find more cases. Now, as a conclusion, we have difficulties in controlling behavioral factors of measures implementation among travelers. Behavioral risk factors among travelers have not been adequately investigated. The study findings urge for a behavioral intervention to help improve personal hygiene and hand washing, early reporting of symptoms, and compliance with isolation measures. And of course, a reconsideration of currently implemented isolation policies where symptomatic and healthy cabin mates are isolated in the same cabin.